Dear colleagues, today you are going to hear a presentation about a very hot topic in oncology, about personalized medicine. My vision is that with the advances we reach in precision medicine and individual molecular targeted therapies, the life expectancy and life quality of cancer patients can be improved in a very certain level. And in line with this, my mission is to find biomarkers which can guide optimal therapy sequencing in both prostate and bladder cancers. And according to this mission, we've got two ongoing projects which are pretty much related with each other. In both of them, we are investigating a novel molecular subgroup of metastatic castration-resistant prostate cancer patients. So let's move on with the first project. I would like to highlight that prostate cancer is the most common cancer in males. It affects 1 out of 8 people, 8 men in the United States, according to the CDC. And 10% of the advanced cancer cases are the so-called BRCA or BRCA mutation positive. After the nice presentation of István, I don't want to tell you more about this gene. I would like to add that probably this is one of the most famous genes of all time, because it was the one because of which Angelina Jolie underwent a prophylactic mastectomy. She had a germline mutation in that gene, which can affect in breast cancer. But based on the studies of the past 10 years, the effect of the gene was very highly researched in prostate cancer as well. It results in a 50% shorter survival for the metastatic prostate cancer patients. It's a much more aggressive disease than the wild-type patients. And I would like to tell you that in the treatment of mCRPC, we can choose among the various kinds of agents. In the first lines, generally, we use the new generation anti-androgens, abiraterone, enzalutamide, or the classic docetaxel treatment. And in the later lines, we can choose among we have several other options, which I will talk about later. So in this first study, we are focusing on the first and second line therapeutic options in this novel subgroup of patients. We are, since we haven't found any interventional studies which would compare these kinds of agents in this selected subgroup of patients, we decided on performing descriptional meta-analysis in the COCOPOP framework, in which we are assessing different outcomes, one of those is the PSA 50, which is a dichotomous outcome. It means that if a patient had a PSA 50, if a patient had a PSA decrease at least 50% from baseline, then that patient had a therapeutic answer for the treatment. And among the others, we are doing research with time to event variables as well, with PFS and OS, but I'm going to present you now our outcomes, our results with the PSA 50 outcome. So we performed our systematic search last year in October, and we ended up by 19 articles until the end of the selection process. So now let's move on our results. Let's see what happens, what we can see regardless of treatment time if we don't make a difference between the first and second treatment lines. In the case of abiraterone, 53% of the patients had a response. In the case of enzalutamide, 56%, and in the case of docetaxel, the chemotherapy, 47% of the patients reached therapeutic answer. In all of the populations, we can say that they are quite homogeneous, and we can see some outliers, like in the case of Annala or Wyatt. And I have to add that fortunately we could work with individual patient data tables, which were in the supplementary of the articles, so we could assess the baseline characteristics of the patients in at least 60 or 70% of the cases. And doing a research on that, we found that this kind of outlier ship can be the result of a poorer general condition of the patient. It means a higher ECOG status, and these patients disease were in a much more advanced state, meaning that they may have visceral metastasis, which can lead to death or to progression, to faster progression. And now let's see what happens if we divide the treatments for first and second line treatment groups. In the first line, 52% of the patients had a PSA 50 response by abiraterone, while 64% of patients had a response for enzalutamide, and for docetaxel, 55% of the patients had a PSA response. Now again, with only one exclusion, or with only one outlier, we can say that these are quite homogeneous population, and the outliership is the same just as I mentioned before, and we can say that enzalutamide has the highest therapeutic answer in the first treatment line. And now let's see what happens if we assess the question in the second treatment line. In the case of abiraterone, 36% of the patient got a response. For enzalutamide, it's 46%, and for docetaxel, it's around 42%. Again, our populations, you can see quite homogeneity, and for enzalutamide and docetaxel, we saw the highest answer rate, but while you could see that in the second treatment line, all the treatments had a lower response rate than in the first one. Our study definitely has some strengths. I would like to start with that this is the first meta-analysis in the topic, gathering data on PSA 50 and other time to event variables. And fortunately, we could work with individual patient data with baseline characteristics, and we will be able to do some statistics or some cohort-like statistics in our practice. But of course, we have to talk about our limitations as well. And definitely, the small sample size is a major limitation we have to concern. And the other thing which I have already talked about in the beginning, that there are no studies which would compare directly the agents in this selected molecular subgroup of patients. As a conclusion, we could, as we could see, the highest proportion of patients had a PSA 50 response in the enzalutamide treatment group, and this difference was the highest or the greatest in the first-line therapy. I would like to highlight that I think almost all of the oncology guidelines now advise to perform molecular diagnostics and perform BRCA mutation testing. So therefore, there are going to be more and more patients who are in the beginning of their chemotherapy series, of whom we will know they are BRCA mutated patients. So it's very important to do researches in this field, and based on our research, these patients can benefit the most from enzalutamide treatment. And it would be very important to perform molecularly selected, molecular marker-driven interventional studies to compare these agents. As I've told you before, in our second study, we are assessing the same way, the same population, but the later treatment options. And like PARP inhibitors, PSMA lesion therapies, cabazitaxel, and platinum. And there are no interventional studies. Again, we would like to assess these same outcomes and the clinical implication I just talked about. And we have performed a systematic search last week, and we are progressing with the selection. We are about 50% in the title and abstract selection. So to sum up, you could see two projects on the BRCA-positive mCRPC patients, therapeutic options and the therapeutic answers. And I would like to thank you for your attention.
I'm really curious. We are talking about this kind of mutation, but is it a homogeneous background, or is this population a very homogeneous population? I mean, if you are looking at the plots, we are seeing, of course, that there is a certain kind of heterogeneity. Of course, with this low number, it is hard to assess heterogeneity, to assess what can be the background. But when we are talking about BRCA mutation, is it really only one kind of disease?
That's a great question. Thank you very much. Fortunately, we had the chance to look into the individual patient data, and in many cases, we have the data about the exact mutation profile of the patients. And based on this, it can happen, of course, that the mutations are not that homogeneous. We can make differences between germline and somatic mutations as well. And of course, the mutation, so it's very important to assess that in what kind of effect does the exact mutation have on the protein level. All of these studies and the data we included from the individual data, where we had the chance to include them, are deleterious loss of functions causing mutations based on the big online international mutation databases. But it can happen, of course, that we can find if we dissect it in a smaller and smaller level, we can find differences. For example, between the germline and somatic, because in our case, we included both of them. But fortunately, we have the opportunity to deal with the individual patient data. So we may find something about it. But in the framework of this meta-analysis, the sample size is so small that we cannot really divide it to lower percentages or to smaller samples.
And Tamás, I think it's very important. Whom and at which age would you recommend the BRCA screening?
Yeah, thank you for this question again. It's very important that based on the NCCN guidelines, every advanced metastatic, every metastatic advanced castration-resistant prostate cancer patients should undergo molecular testing. And in addition to this, those patients who do not have metastasis, but they are very young, under or around the age of 40, they have positive, or they had a relative who had breast cancer in a younger age, or there is a familiar history, which there can be suspicion for having a germline mutation, then we have to do it for those patients as well in a younger age and at the start of the treatment, even for the localized disease.